Good morning. Welcome to Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. My name is Stephen Little, and I'm the Program Director for the Core Cardiology Fellowship. Today, it's my privilege to have with me today our two special guest speakers. We have two of our graduating fellows that I'll introduce individually. This is something we started doing just a few years ago, was inviting our graduating fellows to give a shared grand rounds, splitting the hour between two interesting talks. And we're privileged within this difficult COVID environment to be able to offer these to you digitally, if you will, or virtually. Just a couple of messages. So I will point out, if you haven't already seen the slide go by, during the talk or at the very end of each of the talks, there'll be an opportunity to ask interactive questions. So that's using the Poll V system. You'll get a reminder slide, and there it is there. So you simply, the easiest way is to just text the words DeBakey to the number 37607, pose your question. We'll see them all and try to answer them in order or in order of priority. Only other thing is that for those seeking CME credit, there was already a notification that went by on how to do that. If you missed that, it'll be presented again at the end. Okay, so without further ado, it's my privilege to introduce our first speaker today, Dr. Miguel Castro. Miguel, born in New York City, did his medical training, medical school training in, where was that? Oh, in the Dominican. Then internal medicine at Cleveland Clinic, and then cardiology here. We're very fortunate to have Miguel returning to us next year to do an advanced heart failure fellowship. So that is his interest, advanced heart failure. And today he's going to talk about cardiac sarcoidosis, the great Masquerader, and posing the question, has it now been unmasked? So Miguel, over to you.
Well, good morning, everyone. Thank you, Dr. Little, and thank you to everyone for joining us today in our virtual grand rounds. Like he mentioned, today I'm going to be talking about cardiac sarcoidosis. I have no disclosures today. And so over the next 25 minutes or so, I'll be showing you why cardiac sarcoidosis has been considered one of the great masqueraders. I'll give you an overview on what we know and what we don't know regarding its pathogenesis and etiology, epidemiology, clinical manifestations, evaluation and diagnosis, management, and the natural history and prognosis. But first, a definition. Based on the World Association of Sarcoidosis and Other Granulomatous Disorders, sarcoidosis is a multisystemic disorder of unknown cause. The diagnosis is established when clinical radiographic findings are supported by histological evidence of non-caseating epithelial cell granulomas. And granulomas of unknown causes and local sarcoid reactions must be excluded. In terms of its history, sarcoidosis was first described over a century ago in 1877 by Sir Jonathan Hutchinson, who was the same English physician that described many of the clinical characteristics of syphilis. He described the case of a young co-worker that developed skin lesions on his arms and legs, and the patient also had gout, so it was thought that he possibly had another manifestation of his disease. And over the next several years, similar cases were described, but it wasn't until 1892 that the first histology was obtained. And in 1899 was the first time the term sarcoidosis was used, when Dr. Carl Boak, a Norwegian dermatologist, thought that the skin lesions looked a lot like sarcoma, but since it was benign, he called it benign, multiple benign sarcoid. In 1915 was the first time it was described as a multisystemic disease, and in 1944, nearly 70 years later, was the first time that we described sarcoidosis in the heart in its first histopathological description. In 1951 was the first time steroids were used for treatment, and in 1980 was the first time imaging was starting to be used to help in the diagnosis of cardiac sarcoidosis. So now, speaking about the pathogenesis and etiology, although it's not completely understood, it's theorized that the pathogenesis of sarcoids regards three components. First, an external antigen, whether it be infectious or environmental, which is believed to enter the body through inhalation. Second, a genetically predisposed host. And third, an abnormal response by the immune system, mediated predominantly by the CD4 Th1 cell response in the early phase, and then later on by certain cytokines such as TGF-beta and a Th2 response that leads to chronic inflammation and fibrosis. Looking at the possible etiologies, several factors have been proposed, including tuberculosis, insecticides, and more recently, Propionibacterium acnes. And there was a study done in Japan looking at tissue from multiple patients, including sarcoid patients. And these patients were stained with monoclonal antibodies against P. acnes. And what they found was that patients that had sarcoid were positive. When looking at genetic factors, it has been shown that patients with sarcoid have an upregulation of IL-1 and other cytokines. and also mutations in several HLA molecules. And this study done here in the US looked at the combination of gene and environmental combination. So patients that had exposure to insecticide and also had an abnormal HLA molecule were more likely to have sarcoidosis than those that didn't. Moving on to the epidemiology. So how common is cardiac sarcoidosis? It's actually difficult to estimate at this point, and it's for several reasons. First, the case definitions have been inconsistent throughout the years. And second, many of these cases are diagnosed at the time of autopsy. Nonetheless, based on the studies that we do have, we know that symptomatic cardiac sarcoidosis occurs in about 5% of patients that have extracardiac sarcoidosis, and asymptomatic cardiac involvement occurs in about 25%, again, based on autopsy studies. However, only about 40 to 50% of these patients will be diagnosed during their lifetime. Another well-known phenomenon is that the cases of cardiac sarcoidosis have been increasing steadily over the past 25 years. The study here on the right, looking at a study from Finland, looked at cases over a 25-year span from 1988 to 2012, and what they found was there was a 20-fold increase in cases over this time. And in our own US registry, we see that the percentage of patients who had heart failure with cardiac sarcoidosis increased 5-fold during this time, from 1994 to 2014. And also, its contribution as a cause of cardiomyopathy increased from 5 to 15%. So are we dealing with an epidemic? Well, obviously we're not. The thing is that we're having better imaging modalities, and we're being more thorough with our investigation in cardiac sarcoidosis. But this does complicate further knowing how common it actually is. Moving on to the clinical manifestations, one important point to make is that although as cardiologists we'll deal with the cardiac involvement of sarcoidosis, it's necessary to recognize that it's a multisystemic disease. And cardiac involvement is actually only the 4th most common manifestation behind respiratory, skin, and GI symptoms. However, this is actually helpful for us because if we have extracardiac manifestations in a patient with a cardiomyopathy, then this helps us point to the direction of cardiac sarcoidosis. Now, some caveats for clinical manifestations in the heart. It may actually be the first presenting feature of sarcoidosis. In 1 out of 3 patients, it's actually isolated to the heart. We can have cardiac involvement without symptoms, like I mentioned before. And the cardiac manifestations can occur many years after having another form of sarcoidosis. So when affecting the heart, it can be electrical or it could be structural. The electrical manifestations are AV block, VTVF, these are the 2 most common manifestations, bundle branch block, SVT, and sudden cardiac death. And we're looking at the structural manifestations. We have heart failure, which is actually the 3rd most common manifestation, and it can present acutely as a myocarditis or more insidiously as a dilated cardiomyopathy. Ventricular aneurysms and wall motion abnormalities when it's focal, and valvular regurgitation, which can be it can affect the valve apparatus itself with inflammation, or can be more of a functional regurgitation. Recurrent pericardial effusions, which can lead to constrictive pericarditis, and there have been cases of it affecting the coronaries and presenting as an ACS-like picture. One more point to make is that the manifestations will depend on the anatomic location of the granuloma, as well as the extent and the activity of the disease. As you can see on this cartoon, if we have minimal involvement, you'll have an asymptomatic patient. Once you start involving the interventricular septum more, you'll have heart block. And once you involve the once you involve the LV and have more fibrosis, you'll have VT plus or minus heart failure. And then looking at the frequency, we understand why AV block and VT are the most common manifestations, as the interventricular septum and the LV free wall are the most commonly affected areas. And then finally, before moving on, it's important to note that cardiac sarcoidosis can have several atypical presentations, appearing to be other rare entities. These are all cases of possible LV non-compaction, ARVC, and HOCM that were actually ultimately diagnosed as sarcoidosis. But by the same token, we have to recognize that not all non-CAD patchy scar means cardiac sarcoidosis. We could be dealing with amyloidosis, myocarditis, amongst other entities. Now speaking about the evaluation and diagnosis, although cardiac MRI and PET are the mainstays of evaluation in sarcoidosis, there's definitely value in other initial testing. First, we have EKG, which is usually abnormal and manifest disease. However, it could be completely normal and clinically signed disease, and only positive in about 3 to 8% of patients. There are multiple different manifestations, including bundle branch block, AV block, like I mentioned before. And there was a study done here in the US that looked at patients that had bundle branch block and elevated T-wave amplitude in AVR in patients that had extracardiac sarcoidosis, and it was highly sensitive and specific for actually having cardiac sarcoidosis. In terms of biomarkers, many have been studied over the past few years. However, none have shown any utility. However, troponin has recently been proposed as a possible marker of treatment response, but this was only seen in one small study. Moving on to echo, this is another good screening test for sarcoidosis, as it has different manifestations. Although it could be completely normal, we can see a range from focal aneurysms all the way to a dilated cardiomyopathy. And you can see other things such as increase in wall thickness, LV-RV dysfunction, region wall motion abnormalities, as I mentioned before. And then one finding that's highly specific for sarcoidosis is when you have thinning and hypokinesis of the basal interventricular septum. And this is it when you have a normal coronaries. And it's been shown in a small study that patients that have this finding actually have a worse prognosis. But the problem with echo is that it has a low sensitivity at around 27% and a specificity of 98%. However, when we look at global longitudinal strain, it'll increase in sensitivity to 59%. This was a study done in patients that had extracardiac sarcoidosis, and what they found was that patients that had a GLS less negative than 17.3 compared to more negative than 17.3 actually had a worse prognosis. Moving on to the more advanced imaging modalities, cardiac MRI is one of the most widely used modalities for many good reasons. First, it has a high sensitivity and specificity, and it has many clinical uses. It can provide prognostic value when looking at late gadolinium enhancement. It has been shown that patients that have LGE have worse prognosis. We can look at wall motion function and hypertrophy and wall thinning on T1 imaging, and we have an indication of edema and scarring on T2 imaging. When fused with FDG PET, it improves accuracy. It's also helpful to improve diagnostic yield when doing biopsies in the heart. And we can also assess silent cardiac sarcoidosis. However, it does have some limitations, as we're unable to perform this in patients that have significant renal impairment. It's been indicated that patients that receive steroids prior to getting the imaging can affect the accuracy of LGE, and there's no specific pattern. However, it has been described that it's more commonly seen in the basal segments as well as the interventricular septum. Moving on to cardiac PET, it's also been shown to have a high sensitivity and specificity with also multiple clinical uses. Since we're looking at inflammation, we can detect disease early, and for the same reason, we can monitor for ongoing inflammation and response to treatment. Also, since we're looking at the whole body, we can evaluate extracardiac involvement, especially the lung. And in patients that have ICDs and permanent pacemakers, it's actually the preferred modality, given the fact that you have a lot of artifacts on MRI. But it also has a limitation. First, we're exposing the patient to ionizing radiation. It requires a meticulous patient preparation, given the fact that at baseline, the myocardium has 20% of its metabolic needs are met by glucose, so we have to suppress this by giving the patient a very high-fat diet for at least 12 to 24 hours, which is sometimes difficult to have the patient do. And we have to image the patient at precisely the right time. And again, like MRI, there's no specific pattern. Now, although the pattern is not specific, the pattern we see on PET does tell us a lot about the disease activity. This figure here shows many of the different scenarios we can see. So on the first one, you see that if you have normal perfusion and you have no FDG uptake, then most likely you're dealing with a normal study. However, if you have a normal perfusion and you have diffuse uptake, then most likely this is a false positive due to poor patient preparation. And then the further you go, when you have normal perfusion and focal increases, most likely you're dealing with an early disease. And the further along you get, if you have abnormal perfusion and no FDG uptake, then most likely you're dealing with a scarred out myocardium. Now, just a few words on endomyocardial biopsy. If we wanted to look for tissue, it's preferred to look for an extracardiac site due to the fact that there's a low sensitivity with endomyocardial biopsy, less than 25%. And it only increases to about 50% when we have voltage-gated biopsies. So the question becomes, what is the role for endomyocardial biopsy? Well, if you have no tissue anywhere else, it's still a good test to do, because despite us having high accuracy with these imaging modalities, these patients could have a different diagnosis, which could potentially have a different treatment and prognosis. Now, finally, looking at the HRS criteria, which is the criteria which is most commonly used nowadays, there are two ways we can come to the diagnosis of sarcoidosis, either a histological diagnosis or a clinical diagnosis. Histological diagnosis is when we have a cardiac tissue and that has a granuloma and have no other cause for the granuloma. Or in the clinical diagnosis, you have extra cardiac tissue plus one or more of the following. Either a cardiomyopathy or heart block that's responsive to immunosuppressive therapy, unexplained low EF, a Mobitz type 2 block or third degree block, or imaging either PET, CMR, or gallium scan consistent with sarcoidosis. But important to remember that not one single of these criteria is specific for the disorder. Now, before moving on, I'd like to present a case that we recently saw just to help illustrate some of these points. So this is a 61-year-old male with a past medical history of AFib, HFrEF, EF in the 30 to 40 range on medical therapy, moderate to severe functional MR, non-obstructive CAD, who presented to the hospital after having multiple hospitalizations for heart failure. And he was referred to our institution for mitral valve repair consideration. And when we saw the patient, we noticed that he had a lot of frequent PVCs on EKG and also looked like a Mobitz 2 with dropped P waves. Sorry. And then when looking at his echo, hold on, give me a second here. We can see that his LV is actually had a normal size. However, his EF was around the 40 range. And then you see some possible regional wall motion abnormalities, and also with significant MR. So given the EKG and the echo findings, we decided to pursue an MRI. And what we found was that there was diffuse subendocardial LGE involving pretty much the whole LV and the base of the RV. So given these findings, we pursued an endomyocardial biopsy, which didn't show granulomas, but it did show mild fibrosis and also negative for Congo red staining. And given our high clinical suspicion, we decided to pursue an FDG PET. And what we found was that on perfusion, there was a small mid and apical septal segment defect. And on FDG, there was increased FDG uptake at the basal anteroseptal walls and the basal infralateral walls, all consistent with an inflammatory process. So putting everything together, we have a patient with an unexplained cardiomyopathy with a low EF, a normal sized ventricle, mitral regurgitation with possibly abnormal wall motion, frequent PVCs, Mobitz 2, and abnormal findings on MRI and PET. So a patient meets 4 of the clinical criteria for cardiac sarcoidosis. So although we don't have histology, we have to think this is sarcoidosis and so proven otherwise. And possibly we think this patient had a valvulitis causing the MR. So before moving on, I'll pause the case here, and then at the end of the presentation, I'll show you what we did for this patient. Moving on to the management of sarcoidosis. So there are 2 main goals. We want to preserve the cardiac structure and function with immunosuppressive therapy and guideline diuretic medical therapy in patients that have low EF. And then we want to treat arrhythmias and conduction abnormalities. But the harder question to ask is, who should we treat with immunosuppression? Should we treat based on the degree of inflammation we see, on the degree of LV dysfunction and arrhythmias? And should we also treat asymptomatic patients? And then the other question is, how do we define treatment success? Is it based on decrease or resolution of FDG uptake, improvement or stabilization of LV function, lowering arrhythmia burden, not needing advanced heart failure therapies? And another question is, if we have clinical response, but there's persistent inflammation on PET, does this constitute a treatment failure? So these are all questions that are yet to be answered conclusively. One question we can ask and possibly answer to some degree is, who should we not treat? These are a couple of studies done in Japan looking at treatment response in patients with cardiac sarcoidosis. On the study on the left, they stratified the patients based on the extent of LGE, and based on large extent LGE or small extent LGE. And what they found was that patients that had large extent LGE had higher cardiac death, hospitalizations, and life-threatening arrhythmias with really no change in LVEF or LV volumes. And then the patients that had small extent LGE did have improvement in their volumes and EF after steroid treatment. And then the study on the right, they stratified the patients based on EF. And what they found was patients that had an EF less than 30% tended not to improve compared to patients with an EF between 30 and 55%. So in summary, if you have a large extent LGE, and you have a very depressed EF, then most likely you won't benefit from immunosuppressive therapy. Now, when looking at the immunosuppressive therapies themselves, we have steroids, and then we have steroid-sparing agents such as methotrexate, azathioprine, amongst others. And as you can see on the table, there are no randomized controlled trials as of yet to assess these different therapies. But there are several observational studies, which I'll mention a few, to show the benefit. And then also to remember, they all have different side effects, which will help you kind of lean towards one over the other, depending on your patient's needs. So looking specifically at corticosteroids, they've been shown to halt the progression of the disease, and also in some studies improve survival. It's also been shown to reverse conduction abnormalities and potentially also help ventricular arrhythmias. The length of therapy is at this point not known. We've seen studies that varies all the way from 3 months to 168 months. In terms of optimal dosing, although we tend to treat patients with high dose steroids, this study from Japan showed that patients treated with less than 30 milligrams or more than 40 milligrams didn't really have any difference in outcomes. How do we taper steroids? Another question we have. And then what's the optimal timing of treatment? This study here from the US looked at patients that were treated with steroids within a month of diagnosis, and they found that when they were treated early, they had an improvement in EF. Thankfully, within the next few years, we should have a trial coming out called the CHASM CS-RCT, and it will be answering many of the questions we have in terms of dosing, steroid tapering, and what the outcomes will be depending on different dosing. So this will be coming out in the next couple of years. Now, looking briefly at some of these steroid-sparing agents, the first one here is mycophenolate. This is a study from Mayo that was a retrospective review in patients that were treated with mycophenolate for a mean of 22 months. And they looked at a composite endpoint of VAD, heart transplant, or death. And what they found was that 63% of them were able to be tapered off prednisone, and the median time to the composite endpoint was quite good at 6.5 years, with only 12% of the patients needing to stop the medication due to side effects. So suggesting some benefit, and it's well tolerated as well. This study also looked at the importance of maintenance therapy. In 28 patients that had treatment-naive cardiac sarcoidosis, they were treated with high-dose steroids, followed by methotrexate plus or minus adalimumab. And what they found was that patients that were maintained on therapy, only 12 to 16% had evidence of FTG uptake on PET, while patients that had the immunosuppression stopped, which were 9 patients, 8 of them had recurrence on PET. And when looking at VT burden, you can also see that the burden was much less when the patients were maintained on immunosuppressive therapy. And then finally, one more study looking at infliximab, which tends to be more of a third-line agent due to the concern it can cause a drop in EF. In this retrospective study of 36 patients that had refractory arrhythmias, severe cardiomyopathy, or persistent FTG uptake, when they were treated with infliximab, they found that they were able to wean off steroids, actually maintain the EF, and had a trend towards a decrease in VT burden. In terms of the conduction abnormalities and arrhythmias, as I mentioned before, you would want to treat with steroids just because they have been shown to have some recovery in their AV node function. And then when looking at device therapies, the indications are the same as for non-sarcoid patients with a few caveats. In patients that have an AV block that reverses, you will still err on the side of putting an ICD or a pacemaker. And in the cases of patients that have an indication for a pacemaker, you actually err on the side of putting an ICD. And this is actually based on the HRS guidelines. In terms of ventricular arrhythmias, about 50% of these patients won't be controlled on antiarrhythmics. So you would want to intensify immunosuppression in cases of FTG uptake increase on PET. But in the cases that you don't have increased FTG uptake, then you'll have to go for ablation. And although it's not curative, it has been shown to decrease a recurrent VT and VT storm. Finally, talking about the natural history and prognosis, these patients tend to go through 1 to 3 pathways. Either they recover or stabilize on medical therapy and device therapy, they progress their cardiomyopathy and require advanced therapies, or they die suddenly before having an ICD, or die from advanced cardiomyopathy if they're not transplant candidates. So the actual prognosis is not well known at this time. There's some studies, this study from Japan, they quoted that the symptomatic cardiovascular patients have a 60% survival at 5 years and a 44% survival at 10 years. However, this study didn't specify patients' treatment, if they had LGE on MRI, etc. Also, it's been shown that in patients that have improvement in their EF, it only tends to be transient in about 50% of these patients, and 1 out of 6 will progress. For prognostic value, like I mentioned before, CMR has been shown to predict outcomes, as patients that have LGE will have worse prognosis. And looking at this study that I looked at several factors, they found that patients that had their age greater than 46 at diagnosis and an EF less than 40% had worse prognosis. And however, patients that had a defibrillator had a better, actually was protective for them. And thankfully, patients that do require transplant have a similar survival compared to those that don't have sarcoid, with a 1-year survival around 90% and acceptable 1 and 3 year waitlist mortalities. And actually, patients that do have sarcoidosis, they tend not to have recurrence based on the fact that they're on immunosuppression, and they're usually maintained on some low dose prednisone. And when looking at prognosis, when patients are bridged with an LVAD, there also are no differences compared to non-sarcoid patients. And in terms of cardiogenic shock, patients that have sarcoidosis, we don't have any current studies. They're just case reports, but they do often require biventricular support due to the high rate of RV involvement. So getting back to the case, to wrap this up, so the patient was started on prednisone and mycophenolate. He underwent ICD implant due to the fact he had an AV block, and an echo and EKG were repeated 2 months later. So you can see on the EKG the AV block is resolved, EF improves slightly to the low 50s, and the MR is now minimal at most. He also had decreased PVC burden, and given the fact he's been treated for a few months now, we are pending a repeat PET. And when we saw him in clinic recently, he developed a skin ulcer. So we're pending a biopsy to confirm what we suspect is sarcoidosis. So having reviewed everything now, can we say that sarcoidosis has been cardiac sarcoidosis has been unmasked? I think without a doubt, there's still a lot we don't know. We have a good grasp on clinical manifestations and how to diagnose this pathology. But there's still a lot we don't know in regards to etiology and pathogenesis. The epidemiology will likely change as we screen more patients, and the management and prognosis will also change once these trials come out. So with that, I conclude my presentation. Thank you for your attention, and I'm happy to answer any questions.
Thank you, Miguel. That was a real tour de force of an interesting area, and it's fascinating to see how much new data there is in this field. We do have time for just a couple of questions, so if anybody would like to text one in, remember you text it to the phone number 37607, put in the word DeBakey, and then you'll be able to ask your question, both for this talk and the next. While we're waiting, I do have a question. The incidence is fascinating, how the diagnostic ability has gone up with novel imaging. The definitions have certainly helped. But as you mentioned, there are environmental factors that may be contributing to perhaps changes in incidence. In the transplant population, where you can have a pathologist actually look at the explanted heart, has there been any signal of increased incidence histologically?
Yes, so actually there was, based on what we know, about 50% of patients are actually diagnosed, these patients that get their heart explanted or have an LVAD, 50% of these patients actually have a sarcoidosis on pathology. So that is something.
And has that changed over time?
So again, yeah, I think around 25% of autopsy studies have shown that these patients that have known sarcoidosis outside of the heart will have sarcoidosis in the heart as well.
Thank you. We do have one question here, probably the last one we'll get to for you. What are the suggested biomarkers to enhance the diagnosis of sarcoid?
Well, so far, as I mentioned in the presentation, there have been multiple biomarkers that have been looked at: vitamin D, ACE levels, troponin, BNP. But so far, none of these have actually been demonstrated to enhance the diagnosis. Troponin, like I mentioned, also has been shown recently to possibly be a marker of treatment response, but this was only shown in one small study.
Okay. Well, good. Well, thank you, Dr. Castro. Really enjoyed that.
Thank you.
All right, it's my pleasure to introduce Dr. Anusha Sunkara. Anusha did her medical school at NTR University Health Sciences Center in India, and then did her internal medicine and cardiology residencies here at Houston Methodist. We're very lucky to have Anusha returning to do advanced heart failure fellowship with us again for another year. Her interest, of course, is in heart failure, but also particularly in peripartum cardiomyopathy, and she's going to talk to us about that now. Over to you, Dr. Sunkara.
Thank you, Dr. Little, for that introduction, and thank you everyone for joining us today for our virtual grand rounds. And as you expect, probably I'm a fellow and I don't have any disclosures. So before going into our talk, I'd like to present a couple of patient profiles that we recently treated these patients at our institution. So patient A is a 37-year-old female. She is G2L2, that is, she had 2 previous pregnancies and 2 living children. So she presented to her PCP with complaints of shortness of breath. She's 4 months postpartum, and she had no complications during her pregnancy or childbirth. However, she had preeclampsia during her prior pregnancy. She had no other medical issues and no family history of cardiac issues. So her PCP noted her to be euvolemic on her presentation. An echo was ordered for evaluation of shortness of breath, which showed the EF was 25 to 29% with global hypokinesis, and the LV volume index was 76 cc per meter square. She had normal RV function, no other valvular or structural abnormalities, and the BNP and troponin were within normal limits. So she was started on metoprolol 50 milligrams, which was later up titrated to 150 milligrams, and Entresto and aldactone. And her blood pressure, which was low normal, precluded aggressive up titration of the medications. So this is patient A. Going to patient B, she was a 30-year-old female with 3 prior pregnancies and 3 living children. She presented to her OBG with complaints of shortness of breath. She was 3 weeks postpartum from her delivery of 3rd child. She had no complications during pregnancy and childbirth. She reported preeclampsia similar to the patient A during her first pregnancy. When she presented, she was noted to be volume overloaded on presentation, and echo, similarly prior to the first patient, showed an EF of 25 to 29%. We do not have information about her LV dimensions. She was admitted to the hospital for IV diuresis, and 1 week later she was discharged on goal-directed medical therapy with metoprolol, enalapril, and Lasix. Unfortunately, we don't know the doses and how aggressively they were up titrated. So I hope you remember these 2 patient profiles, because we'll come back to these patients at the end of the talk. So today my objectives for this talk are to discuss briefly the current epidemiology of the peripartum cardiomyopathy, understand the natural clinical course and the risk factors for peripartum cardiomyopathy, and discuss the mechanism of action of bromocriptine and the evidence for its use in the peripartum cardiomyopathy, and the risk of recurrence in subsequent pregnancies. So peripartum cardiomyopathy, based on the classic work done by Dr. DeBakey and his group, when the NIH convened its workshop in 1997, they defined it as a heart failure presenting during the last month of pregnancy or first 5 months postpartum without any identifiable cause for the heart failure and without any presence of no known prior cardiac issues. It was later expanded to include women presenting prior to the last month of gestation, because they found that patients presenting prior to the last month were clinically indistinguishable from those presenting during the last month of gestation. They defined the LVEF to be less than 45% based on the studies, and the LV dilatation could be present or could not be. And globally, the incidence varies depending upon the region you're looking at. There appears to be a couple of hotspots like Haiti and Nigeria, where the incidence appears to be as high as 1 in 100 and 1 in 300. Coming to USA, the incidence is a little lower, but it varies according to the study you look at. It varies from 1 in 10,000 to 1 in 1,000 to 1 in 4,000 live births. And taking a closer look at the incidence in USA, it appears to be 1 in 1,000 live births, and looking at the national databases, between 2 decades, 1990 and 2002, and 2004 and 2011. The incidence appears to be increasing. So the incidence in 1990 to 2002 was determined to be 2.3 to 4.5 per 10,000 live births, and it increased to 8.5 to 11.8 per 10,000 live births between 2004 and 2011. This is probably because of increasing awareness, increasing diagnosis, as well as increasing maternal age and multifetal pregnancies. So what are the risk factors for peripartum cardiomyopathy? Several observational studies have identified some risk factors, including maternal age. As age increases, the risk for peripartum cardiomyopathy increases, especially above the age of 30, and further increases above the age of 40. African American ancestry places them at a higher risk for reasons entirely not unclear. Preeclampsia and hypertension also places them at a higher risk. The studies have shown that while the background prevalence rate of preeclampsia and hypertension in pregnant population worldwide is about 5%, in this cohort of patients with peripartum cardiomyopathy, they found it as high as 12 to 20%, which for reasons unclear places them at higher risk for peripartum cardiomyopathy. Similarly, multifetal pregnancy and obesity can also put them at higher risk. So what is the mechanism? How does peripartum cardiomyopathy happen? Several mechanisms have been proposed, such as underlying genetic predisposition, maybe some viral myocarditis, vascular and hormonal hypotheses, some autoimmune causes, and it has been proposed that in regions like Haiti and Nigeria, there could be micronutrient deficiency of selenium that could predispose to this condition. Perhaps the most extensive research has been done in the vascular and hormonal causes. Dr. Kleiner and his group developed a mice model in which they deleted cardiac transcription activator STAT3. This transcription activator, which is present in the cardiac myocyte, it protects against oxidative damage. And they found out that in these mice models, the pregnant mice developed cardiomyopathy, but the nulliparous females and the males remained unaffected. So they hypothesized that the STAT3, when it's been taken out, it increases oxidative stress and leads to increased cathepsin D. And the cathepsin D further cleaves prolactin into a 16 kilodalton fragment, which mediates the cardiomyopathic effects. And to further prove this, they introduced bromocriptine in the system, and which led to complete reversal of the peripartum cardiomyopathy phenotype in these mice. So keep this in mind, because as we discuss about bromocriptine later, this formed the basis of the use or the experimental use of bromocriptine in peripartum cardiomyopathy. So how about genetics? Is there a genetic predisposition for peripartum cardiomyopathy? Looks like there might be. So observational studies have shown that there tends to be familiar clustering of peripartum cardiomyopathy cases, and also dilated cardiomyopathy can coexist with peripartum cardiomyopathy. So the IPAC group of investigators, they identified 172 patients with peripartum cardiomyopathy, and they conducted a genomic sequencing to identify variants of about 43 genes which are known to be associated with dilated cardiomyopathy. And they found out a high prevalence of the truncating variants of the titin gene, which encodes the protein titin in the cardiac sarcomeres. Similarly, high variants have also been found in chemotherapy-associated cardiomyopathies and alcohol-associated cardiomyopathies. However, studies have also shown that not all the patients with truncating variants of the titin gene in the general population, like for example, go on to develop dilated cardiomyopathy. So they hypothesized that just in case of chemotherapy or alcohol-associated cardiotoxicity, pregnancy represents a second hit in patients already genetically predisposed to form of cardiomyopathy. So going ahead to clinical presentation. There tends to be a lot of overlap between signs and symptoms of heart failure and typically normal signs and symptoms of pregnancy. So that might be the reason some of these cases are missed during pregnancy. For example, a lot of symptoms like dyspnea on exertion, fatigue, orthopnea, pedal edema, and in physical examination, tachycardia and S3 are typically normally seen in pregnant patients, which leads to missing of several of these cases. I think the two most important features that helps in recognizing underlying heart failure are probably elevated JVD and paroxysmal nocturnal dyspnea, which should not be seen in a healthy pregnant female. So as we've discussed, Most of these cases present 1 month postpartum. That's probably because some of these cases are missed during pregnancy, and most of them present in the ambulatory setting. Minority of patients can present with cardiogenic shock or arrhythmias or thromboembolic complications. How about the diagnostic testing? So echocardiography remains the mainstay of diagnosis. In addition to the LV function, pay attention to pulmonary hypertension, RV function, any valvular abnormalities, and also look at LV apex for intracardiac thrombus. Cardiac MRI can also be used, and it probably helps in ruling out other forms of other etiologies of cardiomyopathies in this patient. But gadolinium should be typically avoided during pregnancy because it can cause high rate of stillbirths, neonatal deaths, and skin disease similar to nephrogenic systemic fibrosis and other inflammatory or infiltrative skin disease in the neonates. During lactation and during breastfeeding, gadolinium is typically considered safe as very minute amounts of the doses that are typically given are seen in breast milk, and only as small as 0.1% of the gadolinium that is present in breast milk is absorbed by the neonate. So it's typically considered safe, although out of an abundance of caution, some centers try to give cautions against breastfeeding for 24 hours after giving gadolinium. So how about BNP or pro-BNP? Does it have a role in the diagnosis of peripartum cardiomyopathy? To understand or answer that question, I think we need to understand how the BNP looks like in a normal pregnant female. Dr. El-Qaim et al. At University of Southern California, they looked at BNP levels in a normal healthy pregnant female, and they found out that the BNP levels are not elevated during pregnancy, and they're also not statistically significant between the first trimester and the third trimester. How about BNP in heart disease? The researchers at University of Toronto looked at BNP in patients with underlying heart disease. They included patients with ranging from congenital heart defects to rheumatic heart disease to underlying LV dysfunction, and they found out, and they compared it to normal healthy pregnant females. And they found out that the BNP in these patients is actually significantly elevated, and there is also a statistically significant difference between the first trimester and third trimester. So although we do not have any data pertinent to BNP trends, especially in peripartum cardiomyopathy, one might say that we can extrapolate this data, and BNP can possibly be used as a rule-out test in evaluation of pregnant patients for peripartum cardiomyopathy. Any other biomarkers that are specific for peripartum cardiomyopathy? Yes, we do. We do have some 16 kilodalton fragment of prolactin that we were talking about earlier, microRNAs, interferon gamma, and soluble tyrosine kinase, placental growth factors, but all these are still in the research phases and they're not yet ready for clinical use. So going ahead to the clinical course of peripartum cardiomyopathy. It's different from other forms of cardiomyopathy in the sense that there is a higher rate of recovery. However, the outcomes are heterogeneous. The IPAC group of investigators conducted a study in which they enrolled 100 women across 30 centers in the United States. These patients who were diagnosed with peripartum cardiomyopathy. These patients were within 13 weeks postpartum. They had an EF of less than 45%, and they had no prior history of cardiac issues. So the event rate or the event-free survival at 12 months without a VAD implantation or transplant was determined to be 93%. So out of the 100 patients, 2 died, 3 required early mechanical support, out of which 2 patients died and 1 patient underwent transplantation, and 2 patients required a mechanical support at 11 months postpartum. And out of the 92 patients in whom we had recovery or event data at 12 months or at the end of the study, a high percentage of them, 72% of the patients, had complete recovery, which was defined as EF more than 50%. 15% of the patients had partial recovery, which is EF less than 50% but higher than what they presented with. 6% had persistent severe cardiomyopathy, which was EF less than 35%, and 6 with major events. So looking at the EF for the entire trend of the EF for the entire cohort, the mean EF for the entire cohort when they presented was 31 plus or minus 10%, and at 2 months and at 6 months it was 53 plus or minus 10%, and then 51 and 53 plus or minus 10%. They've also found a statistically significant difference between patients who presented at less than 6 weeks postpartum versus those who presented more than 6 weeks postpartum. However, this difference was not subsequently consistently proven in other studies. So what factors predict LV recovery and further adverse events? Several factors have been identified in the studies, such as LVEF at baseline, LV dilatation or LV dimensions at presentation, the presence of LV thrombus at presentation. African American ancestry is also an important prognostic factor, and RV systolic dysfunction identified on the echo at presentation, and obesity. Out of these, perhaps LVEF is the most reliable predictor of adverse events long term. Going back to the IPAC cohort of patients, in the graph you look at these graphs represent recovery rates in LVEF less than 30% at presentation, and those with EF more than 30% at presentation. So as you can see, the graph in the red represents patients who had EF less than 35%. The graph in blue represents patients who had EF had minimal improvement, 35 to 49%, and the graph in purple represents patients who had complete LV recovery. As you can see, the patients who had EF greater than 30% at presentation had more higher percentage of complete EF recovery compared to those who presented with EF less than 30%. Similarly, EF less than 30% was also associated with higher event rate. And LV dimensions at presentation also correlate with EF recovery. They found, going back to the IPAC cohort of patients again, they found out that the EF end diastolic dimension more than 6 centimeters at study entry correlated with lower rate or lower LVEF recovery compared to those who had end diastolic dimensions of less than 6 centimeters at presentation. So how about the mortality? It differs based on the region, the racial groups you're looking at, and the duration of follow-up. In the IPAC study, as we've looked at, the mortality was about 4%. However, there were some studies conducted in the United States where they looked at mostly African American patients, and the mortality was higher, 11%. And globally around in regions like Haiti and Nigeria, where there is a lot more higher incidence, the mortality is also high as 15% and 28% for reasons entirely unclear. So going ahead to the management of peripartum cardiomyopathy. So the medical management includes the standard goal-directed medical therapy for heart failure, but attention has to be paid to the safety of these medications during pregnancy and lactation. Many of the drugs that we typically use in heart failure, such as loop diuretics, beta blockers, especially metoprolol, hydralazine and nitrates, and digoxin, they are safe during pregnancy. The medications that are not safe during pregnancy are the ACE inhibitors, the aldosterone receptor antagonists, sacubitril and valsartan, and the ivabradine. Many of these medications are safe during lactation. However, the data for sacubitril and valsartan, we do not have enough data for sacubitril and valsartan. So typically, just have a word of caution while using these drugs in patients who are breastfeeding. And also coming to anticoagulation. So we don't have any robust data regarding the use of anticoagulation. Consider anticoagulation especially in patients with who presented with EF less than 30%, especially because there is a more incidence of LV thrombus in these patients, and also because pregnancy and immediate postpartum period is a hypercoagulable state. So low molecular weight heparin is safe to use during pregnancy. Warfarin is usually typically avoided, especially in the first trimester and also during the last trimester because of fetal embryopathic effects and also due to increased risk of bleeding. And both are safe during lactation. So coming to the experimental treatment, bromocriptine. So we've discussed earlier the basis for the use of bromocriptine in peripartum cardiomyopathy. Bromocriptine was initially introduced in the United States as a means to suppress lactation in postpartum patients, but its use has been associated with several adverse effects. There were case reports of MIs, strokes, seizures in these patients, after which bromocriptine was taken off the market for this indication. So based on the work done by Kleiner et al., they actually went ahead and conducted a proof of concept study in 10 South African patients. So they compared bromocriptine therapy to that of the standard heart failure therapy. So they took 10 patients in each arm. The standard therapy group was treated with Lasix, enalapril, and carvedilol, and the bromocriptine arm was treated with 2.5 milligrams twice daily of bromocriptine for 2 weeks and followed by 2.5 milligrams daily for 6 weeks. And they compared EF at 6 months, and also they looked at the composite endpoint of death, New York class, functional class, and EF at the end of 6 months. And they found out that the EF was higher in the treat arm at the bromocriptine, and also the standard therapy arm had higher number of patients experiencing the composite endpoint. A similar study was conducted in a larger group of South African patients, which had 48 patients in each arm, similar to the prior study, and they also found out a similar results in that the EF at 6 months and at 12 months was much higher in the in the treatment arm with bromocriptine compared to the standard therapy. However, the generalizability of these two studies is limited in the sense that they have two limited number of patients, and two, they were done in entirely a cohort of South African patients. And also, if you look at the control arm, the mortality is higher, which is not the case when we looked at peripartum cardiomyopathy in the United States, where the mortality is much lower. There is also some observational data from German registry indicating a higher rate of LVEF recovery, but the overall recovery rates are not like significantly different. So as of this time, there is no guidelines in United States available for the use of bromocriptine in peripartum cardiomyopathy. However, the European Society of Cardiology gives it a Class 2B recommendation for the use of bromocriptine. So consider use of bromocriptine anticoagulation, along with bromocriptine whenever it's used, especially given that there is increased risk of thrombotic events with bromocriptine, as we've discussed earlier. And also it should be discussed with the patient the risks and benefits, especially the risk of benefits of bromocriptine versus the risk of cessation of breastfeeding in postpartum patients. So in the interest of time, I will skip through these slides. How about the transplant outcomes in peripartum cardiomyopathy? So peripartum cardiomyopathy is the 4th leading indication for transplant in women. From the data from the UNOS database has shown that patients undergoing transplant for the peripartum cardiomyopathy tend to be younger, they tend to be multiparous, and they tend to be having longer waiting times and higher listing status. And also, once transplanted, they tend to have a higher rate of rejection within the first year, and they also have a shorter graft survival and higher rate of retransplant. How about lactation? What would you advise your patients regarding lactation? Would you tell them no, you can, because there is this prolactin hypothesis that could potentially worsen cardiomyopathy? Or would you say yes, because we don't have like any definitive data yet, and also there were some small studies showing no adverse effects with breastfeeding in these patients? I think the risks and benefits should be discussed with the patient, and each decision should be individualized for each patient rather than trying to have a blanket approach. So how about the subsequent pregnancies? What would you advise them? So the risk of relapses depends upon the LVEF recovery. In patients who have LVEF, in whom EF recovered to more than 50%, they have a 20% have relapse, but it's much higher in patients who do not have complete recovery of EF. Based on the work done by Dr. Al-Qaim, if you look at this graph, the bars in blue represent the patients with actually completely recovered LVEF, and the bars in salmon represent patients that of incompletely recovered LVEF, and they represent the data in subsequent pregnancies. As you can see, the patients who have completely recovered LVEF during the initial pregnancies, they have lower heart failure symptoms, they have lower rates of persistent dysfunction, and none or minimal mortality. However, the mortality is higher and the persistent dysfunction is higher in patients in whom the LVEF wasn't completely recovered. So based on these data and several other observational studies, European Society of Guidelines actually recommends against subsequent pregnancies in patients in whom LVEF hasn't completely recovered. So going back to our patients. So the patient A, she had no major clinical events. Her shortness of breath gradually improved on the goal-directed medical therapy, and we repeated an echocardiogram at 3 months, and it reported the LVF to be 40 to 44%, which improved. So she's still on the goal-directed medical therapy, and we plan to repeat an echo at 6 months postpartum. Going to patient B. So her EF remained depressed after 6 months. She had an ICD placed for primary prevention, and the goal-directed medical therapy was up-titrated as tolerated. She had no indication for CRT. However, 10 years after the initial diagnosis, she had progressive decline in her functional capacity. She had recurrent ICD shocks for which she underwent VT ablation, which was not successful. She was admitted to the hospital for decompensated heart failure, and she required mechanical circulatory support. She just underwent transplant a few weeks ago, and she's doing well. She's now 40 years old. The reason I put these two cases is that to kind of emphasize the heterogeneity in presentation and clinical course in peripartum cardiomyopathy. Also, going back to these two patients, I suspect when you talk to them, they mentioned that they had some shortness of breath during pregnancy and during postpartum during their first pregnancy, but they ascribed it to like just typical pregnancy features and taking care of the kid after they've born. So this kind of underscores the importance to take a thorough look at history and physical examination, JVD, and be cognizant of peripartum cardiomyopathy, especially patients presenting who have history of preeclampsia or gestational hypertension. So the take-home points, the incidence of peripartum cardiomyopathy in USA is increasing, especially with increasing maternal age and multi-fetal pregnancies. Paroxysmal nocturnal dyspnea and JVD can help to differentiate typical pregnancy symptoms from that of heart failure. Bromocriptine is still considered an experimental treatment, and you need to discuss the risks and benefits with your patient before you go ahead and start bromocriptine on your patient. And patients with incompletely recovered EF have higher risk of relapse and should be advised against subsequent pregnancies. If they do choose to go ahead with their pregnancy, I think a team-based approach with an obstetric gynecologist and a cardiologist, and they should be closely monitored throughout the pregnancies. Thank you for your attention, and I'm now open for questions.
Thank you, Dr. Sunkara. That was a very nice review, and the case presentations are very clear. We do have a couple of questions that have come through in our POLV system, so I'll go ahead and ask the first one. Are pregnant women getting baseline echocardiograms, BNP tests, and such during the peripartum period?
A pregnant, healthy woman patient does not get a baseline echocardiogram and a BNP during pregnancy or peripartum period. This is from personal experience too. So they do not. But if there is any concern for increasing shortness of breath or any concern for possibly underlying any cardiac etiology or especially in patients with preeclampsia, I think it is reasonable to obtain a BNP and an echocardiogram during pregnancy.
Okay. And then the last question there is, do you recommend hydroxychloroquine as standard therapy?
No, definitely not.
What about bromocriptine?
I think we need more evidence for using bromocriptine. So I think it needs to be individualized. For example, if you take a patient from South African cohort, using bromocriptine in these patients, especially when they have a high infant mortality and they do not have access to clean water, so using it in those patients might increase the fetal mortality too. So in USA, the situation is different. We have more access to formula, access to clean water, so maybe we can use it with more confidence. And in terms of maternal mortality, I think we need more data on bromocriptine before we go ahead and use it.
Great. Well, thank you, Dr. Sunkara, Dr. Castro. Thank you both for participating in our virtual grand rounds, and we wish you both best of luck in your advanced heart failure fellowships next year, although I'm sure you won't need it. Thank you, everybody.
Thank you.